Well, they're not the way they were. I don't believe her. We're gonna test it. Oh my God. You know, it's true. That's not true, huh? That- No, she says, can't get the whole equipment unless you're asking table. Hang it. Start the webinar.
Webinar is starting.
Important electricity. Well, like, come on, I don't know how to work, that's it. I hear clicking. I hear clicking. Okay, now.
Good morning. We're calling the meeting to order. Good morning, everyone. My name is Nina Zadeh, and I'm serving as the designated federal officer for the Advisory Committee on Immunization Practices. Welcome to the September 18 to 19, 2025 meeting of the Advisory Committee on Immunization Practices. I will now go over a few logistical items for this meeting. All presentation slides are available or will shortly be available on the ACIP website. For participants joining by Zoom, a few quick reminders. Please keep your line muted unless you're recognized to speak. When the discussion period opens, use the raised hand function in Zoom if you would like to be recognized. Questions will first be taken from voting ACIP members and ex officio members, followed by liaison representatives as time permits. The Advisory Committee on Immunization Practices is a public body, and transparency and engagement are central to our work. This meeting includes 2 oral public comment sessions, today at approximately 3:50 p.m. Eastern and tomorrow at approximately 1:45 p.m. Eastern Time. Requests to provide oral comments must be submitted online in advance. Priority is given to advance requests, and when demand exceeds available time, speakers are selected through a blinded lottery. 19 speakers were selected for this meeting and have been notified. We thank all who expressed interest in sharing comments. Members of the public were also invited to submit written comments through regulations.gov. The docket number for this meeting is CDC-2025-0454. More details on the public comment process are available on the ACIP meeting website. In accordance with ACIP policies and procedures, members agree to forego certain vaccine-related activities during their tenure. For activities that may enhance expertise, the CDC has issued limited conflict of interest waivers. For example, members conducting vaccine clinical trials or serving on data safety monitoring boards may present on those vaccines but may not vote on related matters. For other vaccines from the same company, members may join discussions but must abstain from voting. At the beginning of each meeting, ACIP members disclose any relevant conflicts of interest. We will now proceed with roll call, beginning with ACIP members, followed by ex officio members and liaison representatives. For ex officio members and liaisons, I will call your organization. Please respond with your full name and confirm your presence. We will begin with the ACIP chair, followed by the members in alphabetical order.
Good morning. My name is Martin Kuldorf. I have no conflicts of interest.
Thank you, Dr. Blackburn. And if you'd like to say something about the background, you can do that as well.
Awesome, great. My name is Hillary Blackburn, PharmD MBA, and I'm honored to join you all as the first pharmacist to serve as a voting member of ACIP. I currently serve as Director of Medication Access and Affordability at Ascension RX, and I earned my Doctor of Pharmacy degree from the University of Mississippi School of Pharmacy and completed a PGY1 residency at the University of Mississippi Medical Center. Over the last 15 years, I've worked across hospital, community, specialty pharmacy, and health plan settings. And as a practicing pharmacist, I have administered hundreds of vaccines and completed national immunization certification. I've held numerous leadership roles within professional organizations, including at the national and state level. I've been a dedicated preceptor for student pharmacists from multiple colleges of pharmacy and serve on the Dean's External Advisory Committee for 2 colleges of pharmacy. I'm honored to bring a pharmacist perspective to the important work that we do as part of the ACIP. And views are my own, not of my employer or other groups of which I am a part.
Thank you, Dr. Griffin.
Good morning. My name is Dr. Evelyn Griffin. I'm an OBGYN from Baton Rouge, Louisiana. I am board certified by the American College of Obstetrics and Gynecology, by the American Board of Lifestyle Medicine, and the Institute of Functional Medicine. I was amongst the first to be a gynecologic robotically assisted surgeon in the nation. In my clinical practice in obstetrics, I had been part of initiatives for maternal immunization, including diphtheria, pertussis, and tetanus. And in my overall practice, I feel like if I was to be given a label, I would call myself pro-informed consent because of medical ethics for discussing risks, benefits, and alternatives with the patient. During the pandemic, I myself was COVID vaccinated. I am honored to be on this community. Thank you for having me.
Good morning. I'm Joseph Hibbelin. I'm a board certified psychiatrist coming to this committee in part for the immense mental health aspects of vaccinations and diseases. I'm a distinguished visiting professor at the University of Bristol in the UK. I have 30 years of research experience at the NIH in basic science, animal, human, and epidemiological studies and data. I have 285 publications with an impact factor of 30. I had to look that up, figure out what that meant. Apparently, it's not only exceptional, but rare. So I didn't know about that about myself. The critical issues I bring to the committee are an appreciation of calculating risks and benefits of getting vaccines and not getting vaccines, backgrounds in immunology, neurodevelopment, and translational sciences. I've been on panels from NATO to the WHO to the National Academy of Sciences twice, to the dietary guidelines twice, to UK parliamentary inquiries, and the Department of Defense and the American Psychiatric Association. Thank you. And I have a neutral mind towards vaccines, approaching this with a scientific equity.
Thank you. We'll skip, for Dr. Levy will join us momentarily. Dr. Malone.
Thank you. Dr. Kirk Mellahone, I first got my PhD from UCSD in physiology and pharmacology, with my thesis being on the mechanisms for inflammation in myocardium. I went on to medical school at Jefferson Medical School, did my residency at Travis Air Force Base in the United States Air Force, then went on to do my pediatric cardiology training at UCSD Rady Children's Hospital in San Diego. Following that, I was served as a pediatrician and pediatric cardiologist in the Air Force. I also served as a flight surgeon and did 2 tours in Iraq as a flight surgeon. I have been board certified in pediatrics and pediatric cardiology for over 20 years. I have experience in vaccinating children and international medicine in over 23 countries, involving those without access to vaccinations. And I currently care for many of those who are suffering from post-vaccine syndrome. Currently, I am a clinical associate professor at Texas A&M College of Medicine, excuse me, and performing inpatient and outpatient cardiology at a children's hospital in Texas. I have co-authored 2 articles on the risk and benefits of COVID-19 vaccines, specifically regarding post-vaccine myocarditis. And it's an honor to be here. Thank you.
Mention whether you have a conflict of interest.
No conflicts of interest.
Thank you. Dr. Robert Malone.
Hi, I'm Robert. I'm Robert Malone. I'm a Maryland licensed physician. I hold a MD from Northwestern University, a master's degree from UC San Diego in the Salk Institute, Molecular Biology and Virology Laboratories. I had disclosures and inventions, multiple patents in the late 1980s and early 1990s having to do with DNA and RNA vaccines. I've been involved in both bench research with numerous discoveries while I was teaching pathology to medical students for many years. I've also completed a fellowship in both pathology and a fellowship in global clinical research at Harvard. I've been involved in designing, developing, and providing oversight for approximately 40 phase 1 clinical trials, 20 phase 2 clinical trials, 5 phase 3 clinical trials. Served as medical director and medical monitor on phase 1 and 2 and 3 clinical trials, mostly focused on vaccines. I am a vaccinologist. I've spent most of my career developing vaccines. And that experience includes significant work with the Department of Defense, supporting a variety of vaccine products. I originally started off in HIV vaccines. I served here in Georgia as head of clinical for a $330 million BARDA contract for developing cell-based influenza vaccines focused on the clinical aspect of that. I have experience in plague, anthrax, V, tularemia, tuberculosis, Ebola, Zika, ricin toxin, botulinum toxin, and engineered pathogen vaccines. I hold or have been granted a secret clearance by DoD. I have over 100 papers, something like 15,000 citations, and have really extensive experience in public policy as it relates to vaccines, including serving in multiple times as study section chair for typically large contracts at NIH, been an advisor to the World Health Organization on multiple topics relating to infectious disease and made presentations at WHO about vaccine technology, particularly for influenza. I have no conflicts of interest. I thank the CDC and HHS for the opportunity to serve here as an unpaid member of the Advisory Committee on Immunization Practices.
Thank you. Dr. Meisner joining us remotely.
Thank you, Mina. Let me say good morning or good afternoon or good evening. I'm delighted to have an opportunity to participate in the discussions today. I am an independent contractor with Tennell Government Services supporting BARDA, and I'm a professor at the Geisel School of Medicine at Dartmouth. Thank you.
And please state conflict of interest.
Thank you. I have no conflict of interest.
Thank you. Pagano.
Yeah, good morning. I'm James Pagano, a retired emergency medicine specialist with over 40 years of clinical and administrative experience. Over the course of my career, vaccines have provided significant and at times life-saving benefits to hundreds of my patients. These have included tetanus, tetanus toxoid, flu, diphtheria, pertussis, hepatitis B immune globulin, and yes, COVID. I've also been vaccinated myself numerous times against all these diseases and toxicities. So I'm not anti-vax. I am pro the intelligent and informed utilization of these potentially life-saving medications in a manner that reflects the current state of the art regarding their benefits, the target populations, optimal dosing and timing, and yes, of their potential adverse effects in some people, and I have no conflicts.
Hi, my name is Vicki Pebsworth, and my career began over 45 years ago. I started as a bedside nurse where I took care of patients who were sick with vaccine-preventable diseases, and I gave lots of vaccines. I eventually went on to get a degree in public health and health services organization and policy, and also nursing at the University of Michigan. I am recently certified in bioethics. I have previously served on 2 other vaccine policymaking committees for nearly 10 years. I was with the Food and Drug Administration's VRPAC committee, the Vaccines and Related Biologic Products Advisory Committee, and also served on 2 subcommittees at the National Vaccine Advisory Committee, the Vaccine Safety Working Group, and the 2009 H1N1 Vaccine Safety Risk Assessment Working Group. I've also served as a consultant to the CDC's Board of Scientific Counselors and also to the Institute of Medicine on the topic of vaccination and public trust. I have published peer-reviewed literature, and I serve as a peer reviewer for a couple of journals on topics related to vaccination, vaccine uptake, the effects of state laws, and vaccine safety. I currently volunteer as a director at the National Vaccine Information Center and the National Association of Catholic Nurses. My comments reflect my own opinions and not necessarily those of the organizations I am affiliated with, and I have no conflicts of interest.
Thank you, Dr. Polo.
Am I next?
Yes, please.
I'm Raymond Pollock. I'm a semi-retired consultant and former professor and head of the abdominal organ transplantation at the University of Illinois. I was also a principal investigator in multiple clinical trials, as well as a principal investigator in NIH-sponsored research in transplant immunobiology. I'm happy to be here, and thank you for the opportunity to be of service, and I have no conflicts of interest.
Thank you, Dr. Stein.
Hi, I'm Dr. Kathy Stein. I'm a professor of epidemiology. My PhD is in epidemiology and biostatistics, and I have a 20-year career of focused in infectious disease epidemiology with over 115 peer-reviewed publications and several review papers and other things besides. I've also done some work in bioethics, especially focusing on informed consent. And I've mentored several master's and PhD students who have gone on to careers in public health and medicine. Much of my infectious disease research has been collaborative in the field of immunology and thus has had implications for vaccine design. I am a professor of epidemiology at Case Western Reserve University. My views are my own, and I have no conflicts of interest to report.
Thank you. We'll move on to our ex officios, starting with CMS. Please provide your name.
Andrew Johnson, Centers for Medicare and Medicaid Services.
Thank you. HRSA.
Captain Reed Grimes, Health Resources and Services Administration.
Thank you. IHS.
Matthew Clark, representing the Indian Health Service.
Thank you. NIH.
Michael Carilla, representing NIH.
Thank you. And FDA.
Tracy Beth Hogue, FDA.
Thank you. And we'll go back to Dr. Retzef. If you please do your introductions and state if you have any conflicts.
So first, I don't have any conflict of interest. I'm Retzef Levy from MIT. I'm a faculty there from 2006. I have a PhD in operations research. And I've been working for most of my career, academic career, on trying to think about risk-benefit trade-offs and optimization of them in many complex systems that operate under a lot of uncertainty with the great consideration to risk. And a lot of my work has been focused on human health. I've been working for many, many years with clinical teams on the ground, trying to optimize clinical and operational processes in large healthcare systems, working extensively with healthcare data. I've been working on using data to optimize the quality and safety of the manufacturing of biologic drugs, developed drug safety models, epidemiological models, also worked on issues related to access to healthy food, agriculture and food supply chains and their impact on health. And I'm honored to be here and work with my colleagues on the committee and the CDC and FDA today and tomorrow.
Thank you. I will now call the liaisons, and please state your name if you're on the phone. American Academy of Family Physicians.
Good morning, Dr. Laura Morris, representing AAFP. Thank you.
American Academy of Pediatrics. American Academy of Pediatrics. American Academy of Physician Associates.
Good morning, Dr. Sandra De Palma, AAPA.
Thank you. American College Health Association.
Good morning, Ashley Halbritter, American College Health Association.
Thank you. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists. American College of Obstetricians and Gynecologists. American College of Physicians.
Good morning, Dr. Jason Goldman, board certified internal medicine specialist with over 25 years of clinical experience, clinical affiliate professor of general internal medicine at Florida Atlantic University, and president of the American College of Physicians, present.
Thank you. American Geriatric Society. American Geriatrics Society. America's Health Insurance Plans.
Good morning, Lori Kaloya, present.
Thank you. American Medical Association.
I'm Dr. Sandra Freihofer, practicing general internal medicine physician in Atlanta and adjunct associate professor of medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
Barbara Resnick, I'm present representing the ANA. Thank you.
Thank you. American Osteopathic Association.
Good morning, Masood Mahmoudi, American Osteopathic Association.
Thank you. American Pharmacists Association.
Hi, good morning. Dr. Kelly Good, representing the American Pharmacist Association. Pharmacists and pharmacy personnel are the most accessible healthcare providers and serve as the primary immunizers for patients across the country. Our association represents these professionals and is committed to supporting science-driven, evidence-based recommendations that enhance public health. I appreciate the opportunity to contribute to this ACIP meeting. Thank you.
Thank you. Association of Immunization Managers.
Hi, good morning. Molly Howell, representing AIM.
American Immunization Registry Association.
Good morning, Rebecca Coyle, representing ERA.
Association for Prevention, Teaching, and Research.
Good morning, Christy Mullinger, representing APTR.
Thank you. Association of State and Territorial Health Officials.
Good morning, Dr. Meredith Allen, representing ASTO.
Thank you. Biotechnology Innovation Organization.
Phyllis Arthur, representing Bio. Good morning.
Thank you. Council of State and Territorial Epidemiologists.
For Christine Hahn, representing CSTE.
Great. National Association of County and City Health Officials.
Yes, good morning. My name is Dr. Judith Schley. I'm a family physician at the Public Health Institute at Denver Health, and I am representing NACHO, which supports 3,000 local public health agencies in our country.
Great, thank you. Canadian National Advisory Committee on Immunization.
Matthew Tunis, present.
Thank you. Infectious Disease Society of America.
Flor Munoz, Infectious Disease Society of America, present.
Thank you. International Society for Travel Medicine. International Society for Travel Medicine. National Association of Pediatric Nurse Practitioners.
Good morning. This is Stacy Buchanan, doctorally prepared nurse practitioner, as well as instructor, professor at the Emory School of Nursing.
Thank you. National Foundation for Infectious Diseases.
This is Dr. Bob Hopkins, medical director for NFID. We're here for the science and for our patients. Thank you.
Thank you. National Medical Association.
Good morning. This is Naima Joseph with the American College of Obstetricians and Gynecologists. I was not unmuted previously, but we are present. Thank you.
Great. Thank you so much. National Medical Association. National Medical Association. Pharmaceutical Research and Manufacturers of America.
Yeah, good morning. This is Dr. Michael Barr. I'm a board certified and practicing emergency physician and chief medical officer at Pharma.
Thank you. Pediatric Infectious Diseases Society.
This is Grant Paulson with Pediatric Infectious Diseases Society.
Thank you. Society for Adolescent Health and Medicine.
Hi, this is Amy Middleman representing SAM and looking forward to hearing scientific evidence to recommendation presentations that are so critical prior to any public health recommendation. Thanks so much.
Thank you. Society for Healthcare Epidemiology of America. Society for Healthcare Epidemiology of America. Okay, thank you. I will turn it over to the chair.
Thank you so much. Good morning. I wish to welcome all of you with a special welcome to the 5 new experiencing heated controversies about vaccines. And the key question is, who can you trust? Here's my advice. When there are different scientific views, only trust scientists who are willing to engage with and publicly debate the scientists with other views. With such debates, you can weigh and determine the scientific reasoning by each side, but without it, you cannot properly judge their arguments. For this reason, I lament that the American Academy of Pediatrics has ended their participation as a liaison member of this committee. Neither have they accepted my invitation for an open public debate on vaccines with equal time for each, nor an invitation for private conversations. A few weeks ago, the CDC director was removed and 3 members of the CDC leadership resigned, citing divergent opinions about vaccines. On vaccines, this committee is the key advisor to the CDC director, but during her short tenure, she never contacted me as the ACIP chair about any of her questions or concerns, which would have been natural if she had such concerns. Neither was I contacted by any of the 3 CDC leaders who subsequently resigned, except for receiving a good suggestion by Dr. Daskalakis during the June ACIP meeting, which we adopted. Of the 4, Dr. Jernigan has done important research on influenza vaccines, but the others are not vaccine scientists. Why would these CDC leaders ignore us instead of seeking advice from fellow scientists who have spent decades studying vaccines? With other CDC staff, I've had frequent and excellent interactions since I became the chair of this committee, as well as going 20 years back working with CDC. Some are very good, and the rest, they are fantastic. All are hardworking, and I cannot thank them enough for the work they're doing. After the 4 CDC leaders departed, 9 former CDC directors wrote an op-ed in New York Times, falsely claiming that members of this committee are quote, unqualified individuals with, quote, dangerous and unscientific views. This committee has a wide variety of vaccine expertise. Other committee members have already described their own credentials. As a professor at Harvard Medical School, I develop epidemiological and biostatistical methods for post-market vaccine safety studies that CDC regularly uses, including 3 methods used for CDC presentation at our last ACIP meeting in June. I have authored dozens of scientific articles about vaccines with vaccine scientists at CDC, FDA, at leading universities. And I dare to think that my contributions to vaccine research is highly regarded by my colleagues. Since we authored the same scientific articles, are my co-authors also unqualified and unscientific vaccine scientists? Of course not. The majority of our many vaccine safety studies did not find problems with vaccines. So by dismissing us as unscientific, the former CDC directors are de facto questioning not only us and our scientific research, but they're also questioning the safety of many childhood vaccines that we have shown to be safe. The fact is that we are honest vaccine scientists that let the data speak whether the results go in one direction or the other. That is always how science should operate. In April 2021, when CDC instituted a pause on the Johnson & Johnson vaccine against COVID, despite a vaccine shortage during the middle of a major COVID wave, I was the only vaccine scientist to publicly object to that decision, one that I believe led to unnecessary death among older Americans. After noticing blood clots in post-vaccination young women, it was reasonable to advise them to take another vaccine. But the decision to remove the Johnson & Johnson vaccine from all ages must be viewed as one of the most disastrous vaccine decisions ever made by CDC. Because of my public objection, I was fired from the CDC committee that was monitoring the safety of COVID vaccines. But 4 days after firing me, CDC lifted the pause as I had suggested. At this time, I was clearly the most pro-vaccine scientist in the country, while becoming the first person fired by CDC for being too pro-vaccine, simply because I chose to debate the science rather than go along with the crowd. As this committee clearly stated at our last meeting, we strongly support the use of vaccines. At our last meeting, all our decisions were pro-vaccine. This includes the vote to remove mercury for vaccines. Mercury is a known toxin, just like lead and cigarette smoke, and we should minimize exposure to such toxins as the effect is cumulative. If you had to choose between buying similar hot dogs with or without mercury for your kids, raise your hand if you would pick the mercury-containing hot dogs. Nobody would? FDA has banned mercury from beauty products such as skin creams and soaps. Vaccines are more important than cosmetics. Since there are equally good mercury-free vaccines, removing mercury has only positive public health consequences, while increasing the integrity and trust in the vaccine program. One of the CDC leaders that resigned cited our vote to remove toxic mercury from vaccine as a reason for his resignation. I found that surprising. In contrast to that, I want to take this opportunity to thank the many mothers and fathers who over many years have fought hard to remove mercury for vaccines. You have falsely been called anti-vaxxers, but your stance is not only pro-children, but also pro-science, pro-public health, and pro-vaccines. The members of this ACIP committee are committed to reassuring the public and restoring public confidence by removing unnecessary risk and harms whenever possible. That is a pro-vaccine agenda. While all Western countries recommend important vaccines, such as the one against measles, there's a wide variety in the recommended vaccine schedules. This does not make some countries anti-vaccine countries. The votes that we will take at this meeting falls well within the natural variability seen between countries. We welcome scientific critique of any of our votes, as there are gray areas due to incomplete scientific knowledge. But false accusations that we and other respectable vaccine scientists are unscientific and dangerous anti-vaxxers, that just adds legitimacy to anti-vax positions, damaging both public health and the confidence in vaccines. Such false accusations are only logical if their purpose is political. Again, I suggest that you should only trust scientists that are willing to debate fellow scientists with different views. I hereby invite each of the 9 former CDC directors to have a live public debate with me concerning vaccines. They are Drs. Besser, Cohen, Foge, Frieden, Copland, Roper, Satcher, Schuchat, and Walensky. If they are unwilling to engage in an open and honest debate with the chair of this committee, that they are so severely criticizing, then I advise that you should not trust them. I also make the same invitation to the recently departed CDC leaders. If they want to be trusted, they should all accept. Thank you very much, and then we can proceed with the regular program of this meeting. We have a short update on working groups. We have a number of working groups that are working hard, and that's where a lot of the actual scientific work is going on. And you will hear from some of these, the deliberation of some of these working groups at this meeting. We also have 2 new working groups that we are setting up. One working group on vaccines in pregnancy, and the other one is the childhood and adolescent vaccine schedule. Most of the working groups consider a singular vaccine or a group of related vaccines. But it's also important to look at interaction effects, or if it's best to do one vaccine before another, or concepts of the whole vaccine schedule. So that is what this new working group will be looking into. And of course, vaccines during pregnancy, we always have to be very, very careful and considerate, as with not just vaccines, but with drugs, of anything that we give to a pregnant mother because of risk of, for example, birth defects. So we will have those 2 working groups, and at some point in the future, we will be discussing the results of those working groups at these ACIP meetings. The first topic that we're going to talk during these meetings is the measles, mumps, rubella, and varicella vaccines, they're called MMRV. This is the vaccines where protecting against all these four diseases in one vaccination, in one needle. And that is the vaccine that was developed to replace two separate needles, one for measles, mumps, rubella, MMR, and then a separate needle for varicella to reduce the number of needles that a child receives. We're first gonna hear about the background on MMR from Dr. Arjun Srinivasan from here at CDC. So please.
Thank you, Dr. Koldoff. Good morning. I'm Arjun Srinivasan, Acting Chief Medical Officer in the National Center for Immunization and Respiratory Diseases at CDC, presenting today the background on measles, mumps, rubella, and varicella vaccine. Do we have the slides? There we go. I want to mention up front that this presentation does not include data on safety related to M vaccine, either pre or post licensure. Those data will be discussed next by Dr. Su. Next slide, please. Measles, mumps, rubella, and varicella caused significant health burden pre-vaccine in the United States. Highlighted on this slide are several severe consequences of these diseases. During the last major rubella epidemic in the US in 1964 to 65, in 1 year, 11,000 pregnant women lost their babies, 2,100 newborns died, and 20,000 were born with congenital rubella syndrome that causes deafness, heart defects, and developmental delay. Before the introduction of the measles vaccine, each year an estimated 48,000 hospitalizations and 400 to 500 deaths were due to measles. Pre-vaccine, mumps was the leading cause of viral encephalitis and sudden onset deafness. And for varicella, each year in the early 1990s, 10,500 to 13,500 hospitalizations and 100 to 150 deaths were varicella related. Next slide, please. The introduction of vaccines to protect against these diseases in the form of monovalent and combination measles, mumps, rubella, MMR, or measles, mumps, rubella, varicella, or MMRV, coupled with attaining and maintaining high coverage rates for more than 90%, led to dramatic reductions in disease burden in the US. Elimination of endemic measles in 2000, elimination of endemic rubella in 2004, a 99% decline in mumps cases by early 2000, and a 97% decline in varicella incidence by 2019. Next slide. Two options are available in the US for measles, mumps, rubella, and varicella vaccination. Combination MMRV vaccine or MMR vaccine plus varicella vaccine. Vaccination is recommended as 2 doses with the routine ages being 12 to 15 months for the first dose and 4 to 6 years for the second. The MMRV vaccine available in the US, ProQuad, manufactured by Merck, was licensed by FDA in September 2005 based on non-inferior immunogenicity of the antigenic components compared with simultaneous administration of MMR vaccine and varicella vaccine. The efficacy of the measles, mumps, rubella, and varicella components of MMRV vaccine was previously established in clinical studies with the monovalent vaccines. At the time of MMRV licensure, the burden of disease for these diseases was too low to perform efficacy clinical trials in the US. Of note, immunobridging trials are an established approach for the development of vaccines. Next slide. Immunogenicity after the first dose of MMRV vaccine versus MMR plus varicella vaccines in children aged 12 to 23 months was assessed in 4 randomized clinical trials. 5,446 people received MMRV vaccine and 2,038 received MMR plus varicella vaccines at separate injection sites. In these studies, the endpoints assessed, seroconversion rates, and geometric mean titers were similar between the 2 groups and met the pre-established criteria for non-inferiority. Immunogenicity after the second dose of MMRV vaccine versus MMR vaccine with and without the varicella vaccine in children aged 4 to 6 years was assessed in 1 randomized clinical trial. 399 people received MMRV, 205 received MMR plus placebo, and 195 received MMR plus varicella vaccine. Findings also met pre-established criteria for non-inferiority. As you heard during the last meeting, an ACIP working group assessed the evidence for safety after MMRV compared with MMR plus V in 2008 and 2009. Their assessment on vaccine performance was that given the non-inferior immunogenicity, effectiveness was assumed to be equal. Next slide, please. This slide illustrates the timeline of recommendations for MMRV vaccine use in the U.S. Upon licensure in September 2005 for use in children aged 12 months through 12 years, MMRV vaccine was preferred over separate administration of MMR and varicella vaccines, consistent with ACIP recommendations at the time on preferred use of combination vaccines. In February 2008, a preliminary vaccine safety finding from 2 post-licensure studies that found an increased risk of febrile seizures after the first dose of MMRV vaccine led to ACIP removing the preference for MMRV vaccine use versus MMR and varicella vaccines for both dose 1 and dose 2. After further examining the safety and other evidence, including use of MMRV vaccine has the benefit of requiring 1 less injection than the alternative of MMR plus varicella vaccines, epidemiology of febrile seizures, parent and provider input, and consultation with ethics experts, in June 2009, ACIP issued updated recommendations. Next slide. These updated recommendations are the current recommendations and state that for the first dose of measles, mumps, rubella, and varicella vaccination at age 12 to 47 months, either MMR vaccine and varicella vaccine or MMRV vaccine may be used. Providers who are considering administering the MMRV vaccine should discuss the benefits and risks of both vaccination options with the parents or caregivers. At the time of the publication of the recommendations, CDC provided implementation guidance that, unless the parent or caregiver expresses a preference for the MMRV vaccine, CDC recommends that MMR vaccine and varicella vaccine be administered for the first dose in this age group. For the first dose at age greater than 48 months, and for the second dose at any age through 12 years, that is 15 months through 12 years, MMRV is generally preferred over separate injections of MMR vaccine and varicella vaccine. Next slide. No post-licensure vaccine effectiveness estimates are available for the MMRV vaccine used in the U.S. With measles and rubella being eliminated in the U.S., mumps and varicella at very low levels, there are not enough cases of disease or outbreaks in children to assess vaccine effectiveness in the U.S. Those vaccinated with MMRV or MMR and varicella vaccines continue to have very low rates of disease for measles, mumps, rubella, and varicella in the U.S. There have been no reports to CDC indicating concern for lower MMRV vaccine effectiveness compared to use of the separate component vaccines, consistent with the immunogenicity results seen in the clinical trials. Next slide. As far as utilization, MMRV vaccine accounts for 15% of first dose measles, mumps, rubella, and varicella vaccination among children aged 19 to 35 months. In most states, MMRV vaccine is used for about 10% to under 20% of first dose based on the first and third quartiles. In children aged 4 to 6 years, MMRV vaccine accounts for 75% of second dose vaccination. Next slide. To conclude, MMRV vaccine is one of the 2 options for vaccination of U.S. children for protection against measles, mumps, rubella, and varicella. As the ACIP assessed in 2008 and 2009, given the balance of risks and benefits of a first dose of MMRV vaccine compared with the first dose of MMR vaccine and varicella vaccine, and the importance of individual values and preferences in weighing these risks and benefits, maximizing choice is an important ethical principle, and decisions should be made by providers and parents or caregivers on a case-by-case basis. The 2 vaccination options, MMRV vaccine or separate injections of MMR vaccine and varicella vaccine, are considered equivalent in terms of protection against disease. Due to the current recommendations, most MMRV vaccine in the U.S. is among children aged 4 to 6 years for the second dose of MMR and varicella vaccination. Vaccination for measles, mumps, rubella, and varicella has led to at least a 97% reduction in all 4 diseases compared with the pre-vaccine era. Thank you.
Thank you so much for that presentation. From the members, do we have any questions or comments? Please, Dr. Milone.
Yes. Could you address the issue of how much adjuvant there is in an MMRV versus an MMRV and varicella that are used separately? Is the adjuvant similar or different?
Thank you. I'm going to ask my colleagues. We have a number of subject matter experts on the line who might have that information. Do we have the CDC SME room on the line? Does someone want to address that?
Hi, thank you. This is the NCIRD SME room. There is actually no adjuvant in either of the MMRV or the MMR plus V vaccines. Thanks.
Thank you. Joe?
As many of the members have been interested in risk-benefit assessments, you've described a great deal of the benefits, and you mentioned febrile seizures as a risk. What is your opinion about the risk-benefit ratio of harm from febrile seizures or harm from side effects versus the benefits for the individuals in the population?
Dr. Su is going to present on the risk profile. It's not my position to comment on the risk benefits. Thank you.
Dr. Malone?
Yeah, I just have a blanket statement regarding this topic area. Because of my prior work as an expert witness in the case of Kraling versus Merck having to do with mumps vaccines, because I signed an agreement to allow me to view extensive internal communications within two vaccine manufacturers, I am legally bound to not do any research or have opinions relating to these products because they include the mumps component. So I just wanted to make that clear. I won't be voting, and I have no opinion on this consequent to pre-existing legal agreement from my years ago service as an expert witness in the case of Kraling versus Merck. Over.
Thank you for that clarification. Vicky?
Could you please clarify the difference in the amount of antigen for varicella in the two different options?
Let me turn to the CDC SME room and see if someone has the answer to that question. Thank you.
Hi, this is the NCIRD SME room. Can we have our backup slide number 12? Thank you. On the screen is the amounts, and we have another SME that can comment further.
Yeah, so the viruses and viruses for measles, mumps, and rubella, it's the same between MMR and MMRV. The V component of MMR The V component of MMRV is the same virus as in single antigen varicella, but it's at a higher potency. You can see there are 399 logs PFUs versus about 3.13. So it's about 7 times higher the amount of VZV in MMRV. But the viruses are identical between the two vaccines.
I want to remind everyone to please state your name before you speak. Thank you.
Dr. Levi?
Yeah, just as a follow-up question. So is there a biological or clinical reason for that different amount of antigen? Why when it's being given as part of the MMRV, you need more versus separate? When it's given separately, what is the rationale for that?
Yes, this is Dr. Mona Marin from NCIRD. The initial clinical trials done by the manufacturers had the same amount of V from the single antigen in the MMRV. and the antigenic response, the immunologic response to the V component was suboptimal. Therefore, manufacturers did several clinical trials with different potencies of VZV, and they ended up with this as the best in terms of immunogenic and adverse events. When this issue was discussed in 2008, 2009, the evidence seemed to lead to a potential interference between the measles virus and the varicella zoster virus when they are put in the same vaccine, in the same syringe. We have a stronger response, immunologic response to the measles virus, more fever, more measles-like rash. But we have the same immunologic response after the single antigen varicella vaccine. So that's the reason. It was based on obtaining similar immune response.
And what do we understand of the mechanisms that explains that? Like, I understand the outcomes that you describe. It seems that you observed some outcomes, but do we have a deep understanding of the biological mechanisms that can explain why we see different responses with different vaccines and different combinations?
Yes. There is a final answer if the manufacturer is on the line and can elaborate further.
I think the manufacturer is scheduled to talk later, so maybe they can respond then if they're not available now. Okay, so we'll hopefully get that answer later on. So we're going to continue.
Corey Meisner.
Yes, I know. So before we continue with the next, one more question. Okay.
Yeah. Could you clarify the evidence on immunogenicity after the first dose of MMR if the majority of children develop protective antibodies after that initial dose? What is the scientific basis for recommending a routine second dose? Is it mainly to address primary vaccine failure, waning immunity, or both? And in that context, is there consideration in using antibody titers to verify response after the first dose rather than universally giving a second dose?
Let me ask the CDC SME room if someone has an answer to that. Thank you.
Hi, this is Sarah Oliver with NCIRD. Happy to start, and then we may have another SME who can add. So I would say that antibody titers are one aspect of the protective response. We do know that you see higher antibody titers after 2 doses, and so that is a component of it. We know, especially for the measles component, that the second dose helps pick up the kids who did not have a protective response to that first dose. So 2 doses are recommended. That was what was studied in many of the efficacy studies. And we know that 2 doses provides that additional protection overall.
And do you have the percentages?
So if you want to pull up extra slide 15. That has the seropositivity rates, the percent fold, rise in titer, and the geometric fold for multiple doses for the Proclad, which is the MMRV, or you can see the MMR plus Varivax in the bottom of each of those groups is the separate vaccines.
Do you have any from the primary? This is after the second dose. Do you have any after the primary dose? The sero uptake?
Yes, sorry, slide 13. That is after the.
Pretty good uptake.
Thank you very much. Dr. Cody Meissner, I have you for two topics. So if you address the MMRV Q&A now, and then the other one about the roll call, we'll do a little bit later.